We have to act semi-professional now. All righty. Now, Mary, I just kind of want to get a feel for where you're at, okay?
Okay.
First and foremost, we are all very much looking forward to having your help very soon, okay? We're all very excited to have you on board. I just wanted to make sure I told you that part. And then where do you feel like you're soft? Where do you feel like I can help you the most? Like, do you want to cover some cardiac meds? Do you want to cover antibiotic therapy? Do you want to cover like ICU meds? What's a good place to start? Or do you want me to just start with some of the things I've done in the past and we just go from there?
Wherever, I think cardiac meds would be great, actually.
Sure. Okay, great. Let's talk about some cardiac meds, okay? So why don't we start with our most common problem, a heart attack, right? So what would we start a patient on if they had a heart attack? Can you tell me?
Let's see.
What's the first step going to start? In the ER,
like
elevated tropes.
like epi, I think.
Not necessarily, no. I'm talking a more stable, non-ICU situation here. They came in, chest pain, positive tropes. What would be the first med?
Like nitroglycerin, I think.
That's possible, yes. What would be another med?
Morphine.
Sure, for the pain. What else? Heparin?
Yeah, heparin.
Right? Okay, heparin. So yeah, heparin's a big one, right? Because again, if they have some sort of a thrombus or the chest pain could be related to a PE, right? So we would kind of start that empirically, right? We get them to the cath lab, whatever, we open up a vessel. What will be some meds we put them on afterwards?
Like an aspirin, a blood thinner.
Excellent, good. We don't always do both. There's a really increased risk of bleeding if we do that. But yeah, sometimes we do. Sometimes we do. Okay, so an antiplatelet, excellent. What else?
Like a beta blocker.
Excellent. So we're going to decrease cardiac load, correct?
Yeah.
What does that beta blocker do for us?
It'll decrease our heart rate.
Excellent. So their heart's working less hard, right?
Right.
So that's all very good. Very, very good. Hey, you got this. See, you got this. Good, 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 good. What else are we going to start?
Like
Why
for
do
their
people have
blood
heart attacks?
pressure, like their blood pressure medications, probably
Sure,
like
we optimize the blood pressure meds. A lot of times it's going to be lisinopril, just because if we have an area of dead tissue, sometimes that can lead to hypertrophy. So the lisinopril can prevent left ventricular remodeling, which again is a good thing. And you're right, we're going to optimize blood pressure meds. What else? Why do people have heart attacks?
Why do people have heart attacks?
Yep.
That's a good amount of reasons.
You said blood pressure. What's another big one? What do they have floating around their bloodstream that's too high?
Oh, like cholesterol.
Cholesterol, excellent. So what do we use to treat that?
Like a statin.
Exactly. Okay. So our big three are going to be antiplatelet, correct? Beta blocker, correct? And then it's going to be a statin. Okay. Those would be our big three post-MI. Okay. That would be where you start. Again, if they're a newly diagnosed diabetic, we go into all that prep too. You know what I'm saying? But again, your standard case comes in. They have high blood pressure. They have high cholesterol. We would optimize the blood pressure meds, and we would get them on a statin. Okay? Does that make sense?
Yes.
Okay, great. I'm going to shut this door real quick so we can talk a little bit easier.
Okay.
So that would be one common cardiac ailment. Okay. What will be another one? Do you want to go for like CHF meds?
CHF, yeah.
Okay, great. So what is CHF? Let's start there.
Congestive heart failure.
Okay, so what will be some symptoms?
Like edema.
Yeah. What else?
Let's see. Like a low blood pressure.
Yep, good. What else?
High heart rate.
You could have a high heart rate, correct. What else?
Low O2.
Yes, so shortness of breath. That's a big one, right?
Yeah.
So that edema goes right along, the dependent edema in the legs can also manifest itself in the lungs, right?
Mhm.
So a lot of times these patients come in with a CHF exacerbation and they're put on antibiotics, so they have a positive chest x-ray, okay?
Yeah.
Does that make sense?
Yeah.
Okay, great. So we're talking edema, we're talking blood pressure. What is a very common drug we're going to put these patients on when they get in? I'll narrow it down for you. What's going to help with edema?
Like a diuretic.
What specific diuretic, please?
Let's
I'll give you a
see.
hint. It's not hydrochlorothiazide. It's
Oh,
not spironolactone, although sometimes we do that, but that's an adjunct.
oh my God. I don't, my mind is so blank when it comes to diuretics. Like they're all, I
Okay,
know
well,
them, but what
we're
is
looking
it?
at aggressive diuretic therapy, okay? And because I said aggressive, we're looking at loop diuretics. So
Yeah,
we're
loop
either looking at Fumex or Lasix, okay?
6, yes.
That's what we're looking at. Those are going to be your big ones, okay?
Yeah.
Now, again, let's just take a second to talk about diuretic therapy.
Mhm.
What are we doing with diuretic therapy? Just in broad strokes for me.
You're getting rid of the swelling.
Getting rid of the swelling, and how do we get rid of the swelling? We get rid of what?
Mm.
The swelling is just water, right?
Right.
So we're getting rid of water. What's the mechanism by which we do that?
I'm not sure.
Okay, that's okay. That's okay. We will excrete sodium and potassium because
Yeah.
the water follows the electrolyte.
Yep.
Okay.
Yeah,
So
yeah.
push those off in the urine. So my
Yeah.
next question is, what would be some monitoring parameters here, right?
Yeah.
So what would be a good monitoring parameter?
Their urine output
Urine output is excellent. What else?
or their vitals.
Good, good. What else?
Mm.
I just said we're pushing off potassium and sodium, right?
Yeah, so
So we're
monitor
going to
their
monitor lights. Really interested in that potassium, right? Because again, that gets too low, what happens?
like heart problems.
Yep, exactly. Our heart rate goes to crap, and then we have a big problem on our hands, right?
Yeah.
So that's one of the big things we're going to be looking at, okay? So again, like you said, we're monitoring the swelling, we're monitoring, again, we're going to monitor the O2 sats, right? Because again, if they have the potential pneumonia with the fluid on the lungs, we want to monitor how they're doing there, right? Also, there's another big one that we missed. What is it?
Their
Begins with a W.
W
Mm-hmm.
weight.
Exactly, okay? So again, we want to make sure they're pushing off that weight and they're getting lighter, and therefore we can discharge them home, okay? Does that make sense?
Yeah.
Okay, great. So when you're talking about the CHF, again, diuretic therapy is going to be your big hallmark that you're looking for. And those monitoring parameters, who knows, maybe they show up on the test for you, okay?
Okay.
Some of the other things that we do in CHF, a lot of times they have other comorbidities, like for instance, atrial fibrillation, which can actually cause CHF because your heart rate gets out of control. So that would be one thing we'd monitor, and we'll talk about that in a second. The other thing is we always start them on beta blockers, okay? And, the mechanism for that is not completely understood, but we have data which is extremely convincing, which shows that beta blockers save lives in CHF, okay? So because of that, we start them on beta blockers, okay? It's just how we do it, okay? Now, again, looking at the CHF, aggressive diuretic therapy, and then, really in that population, the blood pressure becomes a commodity, okay? It's not something that, we're trying to make sure they have enough of it, is kind of what I'm saying. And really, all we want them to be able to do is walk and pee. It's pretty much what it boils down to, okay? If they can get up off of the, seat and not fall over, they have enough blood pressure, okay? So we typically aggressively treat the blood pressure as well, all right?
Okay.
There's a med out there, it's called Entresto, and it is extremely aggressive blood pressure monitoring, which is very good for CHF. About 20% of patients fail because they can't tolerate it because of the blood pressure. They go to stand up and they fall over. You know what I'm saying? So
Okay.
again, just something to think about as you're going through this, okay?
Okay.
Let's talk a little bit about AFib. What is AFib? Can you tell me about it?
Yeah. That's when your AFib is common. It's like quivering,
Yes.
quivering of the blood.
Yes. So it's a pooling of the blood in the atria, correct?
Mm-hmm.
Okay, great. So what does that cause?
What does it cause?
Yes.
Causes. God, you're
What does
putting me
blood
on
do
the
when it's
spot
stagnant?
today. What
I'm
is
sorry?
it?
What does blood do when it's stagnant?
It can clot.
Bingo. Bingo. Excellent. That's all I wanted to hear. Clot. Perfect. What does that mean then when we have a clot in our atria?
It's not good.
It's not good. Hey,
Yeah, you can get a
I don't think
stroke.
that's going to be an answer on the test, but you're absolutely right. It's not good.
Yeah, it's not good.
What are we preventing here?
You're preventing a stroke to
Bingo.
happen.
Bingo, bingo, bingo. Excellent, excellent. You got this. I'm telling you, you got this, okay? You're doing great. I couldn't be happier with how you're doing. So we're preventing a stroke with AFib, right? So how do we do that?
So you want to well, if they come in with a stroke or if they just have AFib in general.
Yes, AFib in general. How do we do that? We can go over stroke treatments in a bit. Yeah, that's fine.
So you're gonna put these patients on like a blood anticoag,
Good, sure. What are some options there, please?
like Coumadin.
Excellent. Yes. What else?
They can be on aspirin.
A lot of times they're not. We have data which shows that aspirin is inferior in this regard, okay? Some patients are because they can't actually tolerate a actual anticoagulant. But again, if you're looking at the chest guidelines, what they're going to test you on, the answer is going to be an anticoagulant, okay? Some patients, if they can't tolerate, will go on aspirin. But again, they're the outlier, okay?
Okay.
And again, some patients have reason to be on both. Can you tell me what that would be?
What did you say?
Some patients are on an anticoagulant and aspirin. Why would that be the case?
I'm not sure.
Okay, so if you have AFib, we would slap you on something like Xarelto, right? Okay, great, no problem. Now, what if you also have coronary artery disease?
Oh, right.
Right.
A lot of times
So
they do.
if you have the CAD and AFib, you're going to be on both, right?
Mhm.
So our monitoring parameter for them is going to be bleeding symptoms, right? So what would you tell that patient?
To be careful getting up.
Okay, sure. What else?
Um,
We'll monitor for bruising, right?
yeah.
Blood in the stool,
Yep.
buy an electric razor, all of
Exactly.
those
Yeah.
things, right? So
Yeah.
yeah, that's kind of how you want to attack this whole process, okay?
Yeah.
That's how you want to look at it. Like again, once we hit 2, they're at a great risk of bleeding, okay? And unfortunately, a lot of patients can't tolerate both, so they end up coming off of one, and we got to kind of fly with the risks at that point, okay?
Okay.
All right, let's get back to the AFib thing. So again, you talked about Coumadin. What is our reversal for Coumadin?
God, is it vitamin K?
It's vitamin K, exactly. Photanodione would actually be the brand name. But yeah, it's vitamin K. And it's interesting because a lot of times patients' diets will dictate some of their dosage, okay? So like I worked at the Coumadin clinic for a long time and I had a vegetarian and she was on like 20 milligrams a day. I'd have other patients that never touched greens that were on like, half of a 2.5, 3 times a week. You know what I'm saying? So again, that vitamin K plays a pivotal role in how we dose them in their diet, but also plays a pivotal role if they come in and they're bleeding, right? We can give them vitamin K to reverse it, correct?
Yeah.
Okay, perfect. So again, vitamin K is a reversal agent. I know that came up as a question somebody told me about, so be sure you know that one, okay?
Okay.
Now, what's the reversal for, say, Xarelto?
I'm not sure.
Okay, so I don't know if they're going to ask this, but I figured for completeness sake, we could talk about it. For Xarelto and apixaban, you're talking about 2 options, okay?
Yeah.
We're talking about Kcentra or we're talking about Indexinate Alpha, okay? Mostly Kcentra, because Indexinate's about 60 grand a dose. We don't even have it here, okay?
Mhm.
So yeah, and mostly it's going to be Kcentra. I'd be shocked if they put Indexinate on there, but it's possible. So just so you're aware, Kcentra is going to be your reversal for those agents, okay?
Okay.
And then another option for AFib is actually Pradaxa, and you can file this away in your memory bank. It's a poison that kills people. I have never actually recommended it in my life, but there is a reversal agent that's special for that. It's called Praxbind, okay?
Okay.
So yeah, if you have a relative and they have AFib, make sure they don't ever go on Pradaxa, okay? Please, please,
Oh, God.
please make sure they don't.
I'll take
My
note.
dad got diagnosed with AFib not long ago, and I told him if any doctor even says Pradaxa, punch him right in the nose. So
Oh my God.
anyways, so that'll be some stroke or stroke prevention stuff, okay?
Okay.
Additionally, with the AFib, we could also give them something like Cardiazem to slow down the heart rate, slow down the SA node conduction kind of thing. That's pretty common, okay? But your actual anticoagulant is what's going to be most effective as far as preventing that stroke, okay?
Okay.
Now, what happens if they come in and they've had a stroke?
Right. Yeah. If it's depending on the stroke, right?
Sure, yeah. So we're going to say they have a clot, not a bleed.
Yeah, you're gonna want to give them, I think it's like a 3 or 4 hour window. You can give them TPA.
Exactly. Good. Excellent. Perfect.
Mhm.
We do TPA here. I am very familiar with it. It is weight-based, okay?
Mhm.
But yeah, like you said, there's a window. We want to make sure they're doing fine, and we want to make sure we get it to them, okay? That being said, what is our major monitoring parameter at that point?
Um, mm, mm. When we're giving someone TPA,
Yes, exactly. What becomes our huge monitoring parameter?
their
Well, let's
vitals,
back up a second. What does the TPA do?
it dissolves the clot.
Bingo, it's a clot buster, right?
Mhm.
So what do you think that does to a patient's body as far as abnormally, which we would have to monitor for?
Their clotting factors.
Yes, I mean, sure, that's part of it, but just in broad strokes, what is it? The bleeding risk goes up or down?
Up.
Way up, okay?
Yeah.
And again, you will ultimately have scenarios whereby a patient is given this
Yeah.
and their ischemic stroke turns into a hemorrhagic stroke, okay? I've seen it happen. It's extremely sad, but again, this is the best drug we have at the time that we can give them. You know what I mean? So that's kind of where we are with that. How would we monitor that? I mean, a patient comes in and they're, vented and can't talk. I mean, I can't ask them if they're having bruising, right? What would we monitor?
Their vitals.
Sure, what else? Maybe blood in the stool?
Yeah.
What about like doing another head scan?
Yeah, you can do
Yeah,
that.
okay. So those are the kind of things you want to be looking for, okay? So if they ask you a question about we give TPA, what are we monitoring? You're going to do another head scan ultimately, okay?
Okay.
That's pretty much what we do, all right? So
You
that
said
would be kind
head
of your,
scan or
I'm sorry, go ahead, what?
what kind of scan did you say? It's like a
Oh,
CT?
usually it's going to be a head scan, something like a, what am I thinking of, Melissa? It's
CT or
CT,
MRI.
CT, MRI, something like that, thank you.
Okay.
So that's kind of what we're looking at to make sure they don't have a conversion, something like that, okay?
Okay.
So that's kind of pretty basic. Now, again, why do patients have strokes?
They've probably had one before.
There you go, previous stroke, excellent. What else?
Their diet.
Diet. So again, we can have a overweight patient that has high cholesterol that's not taking care of themselves. What do we do with the cholesterol again?
A statin.
Yeah. So after you've had a stroke, you're put on a statin regardless, okay?
Right.
Because it helps with the systemic inflammation, okay? So we will
Mhm.
always put a patient on a statin, preferably Lipitor, but yes, statin is a hallmark of therapy, okay? If it's related to the AFib, we go over all the AFib stuff and we would do that, okay? But a statin's a big one. And a lot of times it's an antiplatelet as well, okay? So we're talking Plavix, aspirin, something like that, okay?
Okay.
Now, if you have a hemorrhagic stroke, there's a lot less we can do for you, okay? Now, thank God, about 90% of strokes are ischemic, and we do have something we can treat them with. But again, that head CT has to be done, completed, and read prior to giving them TPA, because if you have a hemorrhagic stroke and we give you TPA, do you know what happens?
You're
dead.
all over
It's
the
that
place.
simple. You don't make it. Yeah, it's really that simple, unfortunately. So yeah, we would never give a patient TPA if they have a hemorrhagic stroke. Okay.
Okay.
Again, there's a lot less we can do. Sometimes we try the Kcentra, sometimes we try a couple of different things. Sometimes it's related to the fact that they're on an anticoagulant like Xarelto or Eliquis, and you can try to reverse it. But I mean, 95+% of cases, you're too late. And, the area of the brain is already damaged and it's not going to come back. But, we still do the best that we can for those patients. Okay.
Okay.
I have seen vitamin K. I have seen factor 7. There are a few different options out there, but your hallmark is going to be something like Kcentra. Okay.
Okay.
All righty. That covers our strokes. Let's see, other cardiac ailments we can talk about. Do you have any you can think of?
Yeah, we can talk about left-sided and right-sided heart failure.
Sure. So we already sort of talked about the CHF, which would be the left, right? The right-sided, a lot of that's related to pulmonary hypertension. And there's not a lot of treatments out there for that. Believe it or not, you're probably familiar with Viagra, right? Viagra in a lower dose is called, I think it's Reprevo, but it is actually used for pulmonary hypertension, believe it or not. So it's a medication that we use for pulmonary hypertension, and it actually has pretty good data for the pulmonary hypertension. Now, the tough thing about pulmonary hypertension is once you're diagnosed with it, it's basically a 5-year death sentence. It's extremely hard to treat, extremely hard to control, and it's just not a good thing to have for patients, and it can really cause issue. So yeah, right-sided heart failure, not a good thing to have at all. Okay.
Okay.
And again, if you had a patient that was on that, you would caution them with drinking, because they're taking it all the time versus somebody who's on Viagra taking it some of the time. You know what I mean? And the drinking can also potentiate the decrease in blood pressure for them. So that would just be another thing to tell them. Okay.
Okay.
Also, obviously, the nitrates, you're careful with nitrates. Okay.
Okay.
All righty. What else do you want to talk about? I'm trying to think of other cardiac stuff that I missed. We talked about strokes. Yeah, sure. We can talk about blood pressure.
I feel like that's one thing that every day we're given blood pressure.
Oh, we are. Absolutely. 100%. Yeah, for sure. So let's talk a little bit about the blood pressure. Okay. Your primary agent for blood pressure control in a non-diabetic patient would be hydrochlorothiazide. Okay. That's where a lot of doctors will start. Okay.
Okay.
Now, I have high blood pressure, but I am also diabetic, okay? So I was not started on that. I was started on lisinopril, okay? And the reason is because with the diabetes, you are at risk of microvascular complications in the kidney, okay? So this also helps to protect my kidneys. So it's a double whammy. It's, you get more bang for your buck, you know what I'm saying? So I was started on lisinopril, and that has helped me a lot, okay? So again, your primary agent in a non-diabetic, you would start with hydrochlorothiazide. You would not start with Lasix, because we don't need to be that aggressive right out of the chute, okay? So you would start with hydrochlorothiazide, and you can kind of titrate it to how you need it. And plus, with Lasix, a lot of patients don't want to be on it, because if you're taking it twice a day, you're peeing all night. You know what I mean? So the idea is we need to have a patient on a medication that they're going to stay on. You know what I mean? That's kind of what the guidelines indicate, okay? So that will be your primary agent in a non-diabetic. A diabetic with high blood pressure, absolutely lisinopril, okay?
Okay.
Mary, do you remember the side effect from lisinopril that you might be looking for in a patient?
A hypotension?
That's one, yeah. What else?
Probably a headache.
It could if your blood pressure is low enough, but there's another one that we're missing here.
Lisinopril.
Not related to the blood pressure.
No, I can't think of it right now.
What about the cough? Remember hearing about that?
Oh, yeah.
The dry cough doesn't go away?
Yeah.
Yeah, so that's one of them.
Yeah.
A lot of times, if a patient fails lisinopril, we'll start them on an ARB, or an angiotensin receptor blocker, or as an angiotensin receptor inhibitor, okay? And that would be something like Cozar, something like that, okay? And that has better data with the cough, but you can still get the cough, okay? So that's just something to look out for, okay? You would want to educate a patient on the cough to make sure they understand, okay?
Okay.
Perfect. Now, the hydrochlorothiazide, we're already went over the diuretics that we need to be careful with as far as monitoring parameters. Do you want to do that again, or are you comfortable?
No, I think I'm comfortable, but what
it's the same thing as Lasix. It's just not as aggressive. You know what I mean?
Okay.
Okay, perfect. Okay, now again, some other options for blood pressure, okay? I mean, we're just gonna go broad strokes here. Beta blockers, okay? They have less data with the blood pressure, but they certainly are used, okay?
Mm-hmm.
We can also do something like a nitrate. That will also help, okay? Additionally, we can look at things like I said, the ACEs and the ARBs, that's a big one. But also something like, for instance, amlodipine, okay? That's another good one. That helps to actually like increase the space within our vasculature so the pressure actually goes down, okay? You know, if you think of your cardiovascular system as essentially a bunch of pipes, which is basically what it is, okay? If we are able to increase the volume in those pipes, the pressure will go down. Do you see what I'm saying?
Yeah.
So yeah, that's kind of the mechanism for that, okay? So that's, again, with amlodipine, it's just like we talked about before. Careful getting up off of a chair, right? You want to make sure you can tolerate the medication. They tend to titrate it slowly on the outside, okay? On the inside, they may titrate it quicker because we can watch them 24 hours a day. On the outside, we may go 2.5. They're on it for 2 weeks. We go up to 5. They're on it for 2 weeks. We go up to 10. You know what I mean? So again, that's just kind of how that one works, okay?
Okay.
Questions about that?
No.
Okay, so let's talk a little bit about hypertensive urgency. That's another cardiac element that we didn't quite get to. So I come in, my blood pressure is 200 over 110. What are you doing? We're obviously beyond orals at this point.
Right. So you want to start like an IV drip
Of
cardizem?
Cardizem would be down the list a little bit. We're going to push a couple of things first. What are we looking at?
Oh, you want to push
Two big ones.
adenocard?
No, not adenocard. No.
Yeah. No,
Think blood pressure.
Blood pressure.
Yeah, strictly blood pressure. We have two big agents we use here.
Is it like a calcium channel blocker?
No, it's not a calcium channel blocker.
Okay. Just tell me.
Oh yeah, labetalol. Okay,
Labetalol,
that's
yeah.
one. That's a huge one we're going to push. Okay,
Uh-huh.
that's a big one. The other big one is going to be hydralazine. Okay, those would be two things we'd push right off the rip to get the blood pressure down. Okay, and we'd of course be monitoring their blood pressure to make sure it doesn't bottom out. You know what I mean?
Okay.
So those would be two big ones. Okay, that's what's available. Push. That's what we're going to utilize. Okay.
Mm-hmm.
Now this is a little something you can stick in your back pocket. Mommies, mother baby, and L&D. The best data for blood pressure reduction in that population, also the safest data, is with labetalol, okay? So the reason I'm telling you is because when labetalol goes on shortage, which it does, which is, super, super frustrating, we're always saving for mother baby, okay? And those mommies, because we have the most safety data for labetalol, okay? So we might be pushing hydralazine on patients that we normally don't, but it's just one of those things, okay? Also, we have ACE inhibitors available push, specifically Vasotec. So that's another option that we could utilize, okay? But that immediate blood pressure reduction, we're going to want labetalol and hydralazine in that scenario, okay?
Okay.
And again, we got to remember, right, with our stroke patients, some of them come in with a really high blood pressure, right? So we got to monitor the blood pressure scenario, but also we got to monitor the stroke scenario, right?
Yeah.
It's not all just one thing. Perfect. Okay, good. So yeah, that's kind of blood pressure management in a 10-minute nutshell. Do you have any other questions about the blood pressure stuff?
How much do you want to bring it down, Mary? If they're 200 over like 120.
120, yeah.
what do you want to get them down to?
At-
Say in the first 8 hours.
I mean, at least down to like 180 or like 160.
160, yeah, it's 20%.
25,
20,
25%.
Yeah, so 160 is pretty much the answer, okay?
So you don't want that patient to go all the way down to
The
120 over 80.
No.
You know, we'd be happy if they got to 160, 170 over 90, 100.
Yep.
Because any more like that and they're gonna feel like garbage.
Yep.
So we gotta kind of baby step them down. And then we'll get them there over time.
Yeah.
But you don't wanna drop them too much at
Nope.
once.
Don't want to drop them too aggressively, yeah. They're not going down to 120 over 80 in 5 minutes, that's for sure.
Okay.
At least we don't want them to.
Right.
Any other questions about the blood pressure stuff?
No, not right now.
Okay, great.
What about, John, I'm
yeah,
sorry, I'm
you're
just gonna
fine,
throw
you're
this
fine,
in
you're
here. So what are the couple of drugs that we give that affect blood pressure, but not so much the heart rate? Because there's like metoprolol will do both.
Mhm.
It's kind of a 2-for-1.
Yeah.
We have
You
blood
talking about
pressure,
blood pressure
maybe
lowering? Or are you talking about the
which one
ICU
will
pressors?
bring down the blood pressure but not affect their heart rate because they're already hanging out in the 50s or
Yeah.
60s.
Yeah.
And then maybe we could talk about the rate ones, which ones,
Sure.
which cardiac meds we're giving just for
Sure.
rate, for like those AFib
That's fine,
or.
yeah, that's fine. Sure, so as far as the rate is concerned, like you talked before about the beta blockers, that affects the rate, exactly. So that's basically what we have to affect the rate, okay? Additionally, something like a calcium channel blocker will also bring down your heart rate, okay? To try to help break somebody out of AFib, okay? Now, again, another agent we could give would be like amiodarone, okay? Amio will also affect the heart rate. It brings it down. It can break a patient out of AFib, okay? Those will be your 3 workhorse agents. There are other meds out there that are, I mean, we could talk about them, but they're fairly new and not very popular. I'd imagine on your boards, they're going to be going with what the bread and butter would be. But yeah, that's basically, when you're talking about the rate, those 3 would be your big ones. Beta blockers, calcium channel blockers, and amio, they're all going to bring down that rate, okay? And they're all going to slow down, the conduction through that SA node. You know what I'm saying? So that would be basically what we're looking at. Do you have any questions about any of those meds?
No.
Okay. Amio is available IV. Obviously, Cardiazem is available IV. Low pressure is available IV. We don't start patients on drips of low pressure. It's usually only given push in emergent situations. So that's kind of a standard. We can start a patient on a labetalol drip, which is technically a beta blocker, but that's mostly just for hypertension. Okay, we don't normally give it to control the heart rate. Did you want to add anything?
No, I was just thinking, for some reason, Dig popped in my head.
Yeah, Dig is another one. I'm sorry. Yeah, Dig. We don't put patients on a drip. We put them on a push or PO. And what we call the process is digitalizing a patient. We would give them a load, and then we maintain them on an oral. Okay, so our load is like 500, or it's like 500 followed by 6 hours by 250, depending upon their renal function. And we then maintain them on oral to get them out. Dig, I hate to tell you, they're much better and safer drugs. Dig is kind of old school, and again, it's kind of falling out of popularity. But yeah, we still do it. It's still available, but we just don't do it as much anymore.
I feel like I've sometimes seen a question on NCLEX
Sure.
about the digitalis toxicity.
Sure.
And Mary, do you know what the side effect that they're kind of talk about with digitalis toxicity?
It's not nystagmus. I don't know which one.
The yellow halos
Yes,
that were in the Van Gogh paintings, because they said he had digitalis toxicity.
That's right.
So yellow halos.
Okay. Have you seen that James Bond movie where they give him Dig?
No.
Well, there is one, and he gets toxic on it, but it's the movie, so don't believe that garbage. But yeah, basically, if you are toxic, we do have a med we can give you. It's DigiBind. Not similar to Praxbind, right? They're really creative with their names. But yeah, Digibind is what we would utilize. I've only ever dispensed it, I think, one time. It's pretty uncommon that we would have somebody go toxic. Okay.
What were you saying about the yellow halos? Like, is that? Like, what is that?
That's a symptom of digitoxicity.
If
Oh.
their levels are too high,
Yeah,
because
Yeah.
we can overdo it.
we can measure
Yep.
their dig levels.
Yes,
We
we
can
can.
draw a blood level and see
Yep.
where they're at.
Yep.
But before we know that, they may report a symptom of seeing yellow halos. And
Yep.
that's what that famous Van Gogh painting, Starry Nights, he has the yellow halos in there, and they found out later that he had digitalis toxicity, and that's when he drew that, he was experiencing that as a side effect.
Gotcha.
So that's just an interesting
Yeah,
fact.
just a little tidbit for you.
Yeah.
But yeah, you know, you got to think of it this way, Mary. Who gets AFib? 6-year-olds?
No, like 60-year-olds.
60, yeah. So what do we know about their kidneys at that point?
They're a bit weaker.
Their kidneys can take a walk off the map at any point in time, correct?
Yeah.
And when they do that, they will start to retain dig, okay? And when they retain dig, they get dig toxic. Does that make sense?
Yeah.
See, a lot of these afflictions that we're talking about are with the elderly, and unfortunately, a lot of the medications that we give them are renally excreted, and we just have to walk that tightrope every single day, okay?
Okay.
That's what we do as providers. That's all. It's all part of the gig, okay?
Do you have time to talk about the?
Sure.
I saw some like a couple questions on my test on
Yeah.
like the heart rhythms
Sure.
and how
Yeah.
if you were to see like a different rhythm, how you would treat it, or is that too much?
That I'm not as familiar with. Are you talking about like what we treat a VFib arrest with, or?
Yeah, or like PVCs and like
Yeah,
SVT
I'm not as
and
well
stuff like
versed on
that.
that. I apologize. I could try to look into some stuff and I can email Melissa. Would that help you?
Yeah, I mean if you can.
Okay.
If not,
Yeah,
it's
yeah,
okay.
sure. Give me a little bit of time, but yeah, I can try to email her on that. Yeah, I'm sure I can dig up a reference that would help you. Okay.
Okay.
All right.
Mary, were those on the list that you provided me?
I'm not sure. I think so because I did see like at least like a couple of those on my test.
If you can remember what they are and send them to me specifically, I still have a cardiac phone a friend,
Ah, good.
Jen
Good.
Bless.
Yeah,
Will
Jen. Yeah,
answer.
still no. Jen will
Yeah.
know. Jen's great. I
Yeah.
miss her.
So I can get you some more information on that. If your patient's throwing PVCs, you want to look at if you start seeing PVCs, you want to look at their electrolytes
Big time.
and see if they have any imbalances.
Big time. Big time.
Having electrolyte imbalances, potassium, mag, during a code, sometimes I've seen them even with a normal mag level still be pushing mag.
Yep.
So if you're seeing those, anything funky, look at your lights because your electrolytes are going to, potassium, magnesium, calcium, all of that's really important. So remember that for your test.
Yeah, I can tell you off the top of my head, torsades, we're giving mag, okay? That's a big one. So you got torsades, we're giving mag. That's the cure, okay?
Okay.
Another reason that's important is because when mag goes on shortage, it's a huge problem for everybody, okay? Because the magnesium itself is utilized in so many scenarios where we can't really use anything else. Like I said, torsades is one, okay? If you have a kid who has refractory status asthmaticus, we give mag, okay? And if you don't have mag, you're totally up a river.
What else? Do you know what else you use magnesium for? Like what other emergent situations? And don't narrow in on one. Think
broad.
Yes.
Broad. All patient types.
So we said torsades.
Big one.
We said
Pediatric
status
asthmaticus.
asthmaticus.
Also for adults, but yeah.
Can you think of any others?
There's two more.
No, I can't think of that right now.
Well, there's technically three more. If you have low mag, we always replace it, but that's
right.
not.
Yeah, that one is what I was thinking about. So that would have been stupid.
Okay, that's good. No, you're not wrong. Not wrong. But another big one would be something like status epilepticus as salvage, okay? We can't get you to stop seizing, we will give MAG, that's another option.
Yeah, like,
Again, that's down the list, but it's obviously something we need to have on hand in those scenarios. The other one is, pregnancy, the preterm labor, we give MAG, okay?
yes,
So
yes.
you will see that too. And again, like I said, when it's on shortage, it is a huge headache. Because guess what? We got to have some, And
Yeah.
it's a big headache because everybody wants to order IV MAG for replacement because patients have diarrhea on oral. And I'm just like, look, they're going to have the diarrhea. I got to have this for the mommies, And it's what I tell people all the time, I got to have it for the kids. Yeah, that's, sorry. I mean, you don't like it, talk to my boss. He's going to tell you the same thing. So anyways, that's kind of what you're looking at with that. Okay.
Okay.
I got a few more minutes here. Is there anything else you wanted to cover?
Can I
Yeah.
interject a couple?
Yeah.
What about, I see this is open, what about
Yeah.
insulins?
Yeah.
I feel like
Sure.
insulins, Mary?
Can we talk about insulin for a minute?
Yes.
Sure, let's talk insulins. And if you need to do another session, we can certainly do that. Just let me know.
Okay, cool.
I mean, I tried to cover what I could, but
Yeah.
there's a lot.
Yeah.
Okay, so insulins. So what do we give insulin for?
Lower blood glucose.
Exactly, to lower blood glucose. So what population is that?
The type 2s
And
and
ones?
yeah, and the
Type
one.
ones, yeah. Type ones, it's like the only thing we can give them. Metformin doesn't work for them. You know what I mean? So
Yeah.
type ones and type 2. So basically any diabetic. We also give it with the gestational diabetes because it's got the most safety data associated with it, okay? Now, I will tell you that some people do not want to get poked. So they will go on something like metformin when they're pregnant. I think it's irresponsible, but that's not my call. But they don't want to take the pokes, so they go on something oral. Again, much less data on that, but again, that's, that's between them and their provider. So anyways, long story short, insulin's lower blood glucose. So we have like long acting and we have like intermediate acting and we have like short acting, okay? So what would be something that's long acting? Can you tell me?
Long acting. God, I don't, it's right on top of my head. It's
Okay, yeah, just think for a second.
Lantus.
Lantus, exactly. Perfect. Good. What else?
Let's see. I can't think of one right now other than
that's
Lantus.
okay. Are you familiar with Detamir or Levemir?
Levemir, yeah.
Yep. So those are both long actings, okay? And those are your workhorse long acting agents. That's just how it is. Obviously we have Lantus at the hospital, but again, Detamir we used to have. Those are your two. Those are the two that you're going to see. Okay, that's just kind of how it works.
Okay.
Now again, at the hospital, we're big proponents of something called basal bolus therapy. Okay, so in order to most closely mimic the body's own insulin secretion, we would give you a basal insulin, which would be that long acting, which is what's always being excreted by the pancreas, okay? And then in order to cover you at meals, we would give 3 times a day or sometimes 4, depending upon how bad your diabetes is, bolus doses of insulin that are short acting, that are taken up quicker, that immediately correct the postprandial glucose levels, okay?
Okay.
So actually, can you grab me a piece of paper?
Yep.
Can you turn on video, Mary?
Video, let me see.
Yeah. Actually, all you need to do is be able to see me. I'm just going to write out a quick little graph for you, okay?
Okay.
Does this work?
Sure. Thanks. So again, it's easier to visualize, okay? And I'm going to try my best to do this on here. So yeah, that's fine. And I can just even just, show it like this. But anyways, so your basal insulin is going to be right here, okay? That's your curve. You see that for your Lantus, okay? So this is your basal. This is what your pancreas is always excreting, okay? That's in your body, my body, and Melissa's body, okay? We all excrete insulin at a rate from our pancreas, okay?
Okay.
Now, when you have a meal, your insulin requirements go up, okay? Because again, that blood glucose goes up, right? So 3 times a day, we give extra, extra, extra. So breakfast, lunch, and dinner. Do you see that?
Yeah.
Okay, so that's what your curve looks like, okay? And again, it always helps me to visualize it that way. That's how I always think about it. It's helped me, and I've actually had to give talks about this because once upon a time we were struggling with not giving the Lantus because a patient had a low blood sugar. Unfortunately, you cannot hold Lantus unless you have an order from a provider. It does not acutely correct blood sugar, okay? And because of that, we would give it even if their blood sugar was in the 60s. Now, again, as a nurse, you're thinking the blood sugar is in the 60s. I can't give insulin, which is completely reasonable. But again, it does not acutely correct that blood glucose, okay?
Okay.
Does that make sense?
Yeah.
Okay, great. I'm going to tell you one more thing, and that is we also give insulin in another scenario. Do you know what that is? Thanks.
Oh, what is that?
So we were talking about electrolytes, right?
Yeah.
So hyperkalemia.
Okay.
What do we give?
Hyperkalemia.
Mm-hmm.
High potassium. I'm not.
Yep, we give.
What is that?
Well, it's usually like a 4-drug regimen? Actually, I think it's 5. We give calcium to stabilize the cardiac membrane. That's the first thing we give. We would also give insulin in order to drive the potassium intracellularly, okay?
Yeah.
So again, what does that mean to you? What that means to you is when you have a new diabetic who's a pediatric, for instance, and they're put on high-dose insulin, we're always going to be monitoring their potassium, okay? A lot of times it will be started on maintenance fluids with potassium because of that, okay?
Yeah.
So we drive potassium intracellular. We are not getting rid of the potassium. We are simply making it not in the bloodstream so our labs look better, okay? In order to get it out, we give the K-oxalate, okay? Which then means it is pulled out of the bloodstream and it goes out their poop, okay?
Yeah.
Does that make sense?
Yeah.
Okay, so they will then, excrete it, rectally, and then it'll be out of their body, which is what we want. Anytime we give insulin like that, it's a big dose. It's 10 units intravenous. It's going to acutely drop their blood sugar. So what will we then give in order to correct that?
Wait, can you repeat the question?
Of course. So like I said, 4-drug regimen. When we give insulin high dose intravenously, we are going to acutely drop the blood sugar. So what do we do to prophylax them in that scenario?
I'm not sure.
We give them D50.
D50, yeah.
Yeah, to stabilize things, okay? So we push insulin, we push D50, we give them calcium, and we give them KX. Make sense?
Okay.
All righty, great. I got a split. If you want to run another one of these again with Melissa, just let me know, and we can certainly, I can ask my boss again, okay?
Okay. Thank you so
Was this
much.
helpful, Mary? Did this cover some stuff you think you're gonna need?
Oh, no, 100%.
Oh, great. I'm glad. I'm so happy. That's wonderful. And if that's what you needed, I'm so happy. And like I said, we are all very much looking forward to having your help very soon, okay?
Thank you so much.
Of course, Mary. Good luck, all right?
Thank you.
Thanks, Mary. Have a happy Thanksgiving.
Happy
And
Thanksgiving,
we'll
yes.
try and figure out another one for pharmacy, like pharmacy part 2.
Okay, sounds good.
And I recorded this, so once I get it, I'll send it to you as well as the other ladies. And if you just want to listen to it, to review it again, because there was a lot of really great content.
I agree.
Well, there was content. We don't know if it was great.
Thank you, Mary.
Thanks, Mary. Have a good rest of your day, all right?
Thank you, guys.
Of course.
Bye.
If that helped her, I'm glad. So I got to split my shift starting